Hello, everyone, and welcome back to our second part of Meet the Surgeon, and where we will answer all the questions that we couldn't answer last time. So, once again, we would like to say thank you to Professor Ate van der Zee for accepting to answer all our questions and take the time to record these questions together with us today. So, thank you very much and welcome again, and thank you for accepting our invitation.
Thank you, Houssein, for again inviting me. And of course, I'm happy to answer all the questions by all the NEGO members. So go ahead.
Thank you. So, we have around 10 questions. I will start with the first one. In cases of vulvar cancer developing in a background of severe lichen sclerosis with severe adhesions, it can be challenging to decide if the tumor is midline or lateral. Should you first divide these adhesions under anesthesia to determine on which side the tumor is, or what can we do?
Yeah, that's an interesting question. To be honest, in my career as a gynecologist, we have never brought a patient under anesthesia to determine whether or not the tumor is unilateral, bilateral, or midline or near midline. And also, for example, if we inject the tracer for sentinel node detection around the tumor, we also do not perform incisions of the adhesion. So I would say that in general, it is possible to determine without anesthesia and without incisions to determine whether or not a tumor is midline or near midline or lateral. And for example, if you perform a sentinel node detection, your lymphoscintigram also will tell you whether or not there is a unilateral flow or a bilateral flow.
Okay, thank you very much. It is indeed frequent. We see that very often in consultation. The second question is, if we have two sentinel lymph nodes identified, how should they be managed?
Yeah, so if your lymphoscintigram shows you that there are two separate ways of lymph flow to the groin, resulting in two sentinel nodes, you should also at surgery remove two sentinel nodes. And there is, of course, always an issue how to determine whether or not there are really two sentinel nodes or whether there is overflow from the sentinel node to so-called second echelon nodes. And my recommendation in general is always to remain on the safe side. So if you are in doubt, just cut it out, to be honest. And so that's basically it. You have to remove all the sentinel nodes that were identified on your preoperative lymphoscintigram. And if you are in doubt, take the hot nodes out.
And if so, I will just add a small question. If we combine two two tracers,
Yeah.
and if on scintigraphy we found only one, and then on ICG or on blue dye we found two, then we remove those two also.
Yeah.
So whenever we are in doubt and have more than one sentinel lymph node, even if it's with one tracer only, then we do remove both.
Absolutely. Yeah, because it's of course also dependent on where you inject your tracer exactly around the tumor. So we in our institution prefer it that the one who is doing the preoperative injection is also the surgeon who operates.
And where do you perform your injections around the tumor?
So normally we just do a so-called peritumoral injection, which means, let's say, on 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock.
So you do all 4 points.
Yeah. Yeah.
Okay, and now the next question is about lymphadenectomy. So the question is about how big and in which direction do you usually perform the skin incision, and if it's possible to give some anatomic landmarks.
Yeah. So to be honest, I can of course call the anterior superior iliac spina, for example, and the margin of the symphysis, and we do normally do a transverse incision of around 6 to 7 centimeters, I would say. In fact, normally I would say 1 to 2 centimeters below the inguinal ligament, but it would be better for the people who are listening to this to go to the Ego Academy, where there is a film video from our institution on how to perform an inguinofemoral lymphadenectomy. And in fact, I think there are even more from more institutions. So it's better to look at the video than just to tell it how to do it.
Yes,
It
to
can be
see
very
it.
instructive to look at the video.
True. Thank you. The next question is, what is your treatment approach for contralateral groin in a 3 centimeter primary lateral tumor with ipsilateral micrometastasis?
Yeah. So that is the policy that we now have is based on a publication that was by Van der Kolk et al. In Gynecologic Oncology. I think it was in 2022, where we looked at the risk for groin recurrences in a patient like this. And what we found was that if you have a really lateral tumor based on where it's located and also based on the lymphoscintigram and on sentinel node detection, that the risk of a contralateral groin recurrence in a patient like this is very low. So the recommendation based on this manuscript is that we leave the other contralateral groin also when there is a micrometastasis in the ipsilateral groin.
Okay. Okay. Interesting. And in your so this person is saying that in their experience, wound healing, which is all, I think for all of us, is a significant issue. How do you handle post-operative wound care in your institution to prevent dehiscence? Would you use local agents, antibiotics, hyperbaric chambers, etc.?
Yeah. So this is the $1 billion question, I would say, because this is something that I've been thinking about for the last 25 years, and we have tried all kinds of things during surgery. For example, by doing a transposition of the sartorius muscle, by preservation of the saphenous vein, by trying ligature for dissection instead of just coagulation, for example, or diathermia. And the real answer is that so far, no real impact on the occurrence of short-term and long-term complication has become clear. And then how is our routine post-operative treatment is we close, of course, the groin with the interrupted sutures subcutaneously. Then we use staples to close the skin. We place a suction drain, and we leave the suction drain until there is no more evacuation of lymph fluid, or after 4 weeks when there is still production of lymph. And the point is that it's the complication rates are still very, very high. So I don't have the right answer. I don't think there's any evidence that whatever modification of this policy really helps, like antibiotics, sealing agents, whatever. It really doesn't have a real impact. So there are of course possibilities like doing a flap, placing it on the place where you are going to. So first make the flap, then do your lymphadenectomy and place the flap on the place where you did your lymphadenectomy. That type of modifications, but that still needs to be evaluated in well-designed clinical trials.
Okay. And if you ever have wound dehiscence, what would you do?
We will just open the wound and leave it open and treat it like an open wound. So,
Okay.
yeah.
Okay. So before moving to the next question, I would share something. It's funny, in Lebanon, we used to try something. We used to put honey.
Honey, yeah. And does it help?
Yes, it used to help. And then I discovered that we used to take like real honey. And then I discovered that there's something that's called medi honey, which is treated honey, on tubes of treated honey. And it's actually, well, it used to heal. Like it wasn't magic, but it used to.
But Houssein, that you did that after you had opened up the wound, I guess, for the
Yes.
secondary wound healing.
Yes, for secondary wound healing.
Yeah,
Not
like
for
a VAC,
primary.
like a VAC. Some people use VAC,
Yes, back
that type of
therapy,
thing.
exactly. And some people use a hyperbaric chamber.
Yeah.
Yeah. So, but since we did not have the hyperbaric chamber or the vac therapy, we used to put honey.
And so how do you do it now you're now in Paris, aren't you?
Yes, so when I was in Lille, we used to put vac therapy, and we do vac therapy here now.
Okay.
Yeah. And in some places in France, they do hyperbaric chamber.
Yeah.
And it actually works.
Sure.
But
Yeah.
for secondary wound healing.
Yeah. Yeah. But so it takes a long time before it really heals. And the problem is, of course, that you need, in fact, to prevent this. And the idea, for example, by lymph vascular anastomosis, that type of thing, but that's still all very experimental and not
Yeah.
proven.
Yeah. And now we have a patient now because now I'm out at Gustave Roussy and I'm staying here. So and now we had a patient to whom we did an exenteration and
Yeah.
we put the amentum. We closed the
Yeah.
vagina and we put the amentum, and now she has a wound dehiscence at the level of the vagina. So there's nothing to do. It's just secreting and secreting, and then there's nothing to do.
Yeah. Yeah. That's terrible. Yeah.
Yeah, we just have to wait, and it takes a lot of time. And
That take a very long time. Yeah.
the next question is okay. We will ask a question that's almost related to what we just discussed before. Have you had any experience with full inguinal lymphadenectomy and using superficial circumflex iliac artery flap reconstruction to reduce the risk of lymphedema?
Yeah. So we talked about that, and the answer is no. We never tried that. So I can't comment on that. It would be interesting to explore. I think there are some data that it might help. But the only thing is, of course, that the what you always do with this lymphadenectomy is transecting all these lymph channels, and whatever you put in place of that, you do not really solve the problem. If you want to solve the problem, you have in one way or another way to re-anastomose those lymph channels. So
Yes.
in the earlier days, when I was very, very young, in many patients, so-called lymphoscintigrams were performed by injecting a tracer, radioactive tracer, in the foot, in the ankle, in order to determine where the bigger lymph channels were, and so that you had an idea where these lymph channels, what were the most important lymph channels, because it's also an interesting question, of course, which patient is going to have the severe lymphedema and which patient not, and why, what are the predictive factors for that? And you can imagine that, for example, those patients who have a lot of collateral lymph channels, they might have less complaints after a full lymphadenectomy in the groin when they have all kind of collaterals. While in those patients who do not have those collaterals, you will see a lot of lymphedema. So in the future, I could foresee, for example, that if you have a preoperative lymphoscintigram and you see there's are a lot of large lymph channels in the groin and no others, you should try to, and this is like an idea, not,
Yeah.
but just a kind of fantasy, then you should perhaps consider re-anastomosis of those bigger channels in that type of patients.
That's interesting. And maybe we can, so I'm just thinking with you, and if we do the the lymphoscintigraphy before surgery, and then at the moment of surgery, we put ICG, and this way we can visualize the whole lymphatic channels. So if we put
Yeah.
it way enough before starting the surgery and leave the time so we can see all the channels, not to detect our sentinel lymph node, but actually to visualize our whole lymphatic pathway. Maybe it might help us decide where to go. And
Because it's interesting, in our hospital, the surgeons are also doing inguinofemoral lymphadenectomy in, for example, testicular cancer
sarcoma.
patients, and they do it in a different way. Most gyne-oncologists do this transverse incision for the lymphadenectomy, while they do vertical incisions, and they claim that they have less complications than we have. And so that's another way to explore.
Yeah, maybe we can come up with something.
Yeah.
Really, I will. So another parenthesis, but if I will try to see if we can come up with a study or at least a review on that to compare complications between urologist and gynecologic oncologist.
For example, that would be an interesting idea. Yeah.
The next question is, if there are two positive sentinel nodes and a CT imaging shows no suspicious nodes, would you perform a lymphadenectomy before radiation?
Yeah, for sure, because all our data on radiotherapy are based on one sentinel node metastasis. So if there are two, we would perform a lymphadenectomy and then probably give radiotherapy. Yeah.
And is sentinel node indicated in varicose carcinoma, given it often coexists with squamous cell carcinoma?
It very much depends on the final pathology. I mean, if the final pathology shows that there was also a squamous cell cancer, then you could do a sentinel node detection. But if you only have the data, the preoperative results of a biopsy which shows varicose carcinoma, I would not perform a sentinel node detection.
Okay. And the last question, do you
Yes.
use p53 immunohistochemistry at the resection margins as a predictive factor?
We don't. No, no. And I don't. I also don't see. I mean, it's interesting, but if you want to do that, I think you should do it in a clinical trial or something like that.
And I think it wouldn't, for the moment, it would not change our way of doing things.
No, no, no.
Well, thank you very much for answering all the questions. I would like to thank you on behalf of all our viewers and on behalf of Enigo and ESGO for accepting our invitation the first time and taking the time to answer all the questions the second time.
Okay.
A pleasure.
Thank you, Houssein, for the invitation, and it was a real big pleasure to participate in this whole thing. Thank you very much, and have a
Thank you.
good day.
You too.
Bye bye.
Bye.